Good evening, friends. Welcome to webinar. This is my credentials. Recently, I got award of Icon of Gynecology in 2024. This is my orchid ID. You can say my 112 publications over there. We have got 2 seat of DNB DGO, 2 seat of Foxy recognized ICOG fellowship of laparoscopy and reproductive medicine, and all the training IVF, laparoscopy, and ultrasound at single group in Mahir Hospital. The moment child is born, mother is also born. She is there, mother is something new. With the blessings of mother of mine and so many mother to whom we had delivered, 3 books written by us is recommended as the reading material in Royal College. Likewise, the Atlas of Fetal Echocardiography and the Technique of IVF Made Easy has gone for second edition and now it is available in market. I am editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecology, in which I have published more than 50 research papers over there. Second is Open Research Journal in Gynecology, which is published from Michigan, USA. Today we are going to talk something regarding the unfolding intricacies of recurrent pregnancy loss. Today my agenda will be what is overview of recurrent pregnancy failure, what are the risk factors, what is pathophysiology and mechanism of recurrent implantation failure, which investigation we have to do for this particular patient, and what are the therapeutic intervention for recurrent pregnancy failure. Let's begin the discussion with the first section entitled Overview of Recurrent Implantation Failure. Successful implantation depends on embryo quality, embryo receptivity, and the microenvironment for embryo maternal signaling. You see, only healthy embryo will go into the uterine cavity and it will implant into this endometrium. Here, there should be presence of less natural killer cell, very good pinopodal activity at this particular junction, with presence of osteopontin as a protein which has got very good affinity for the embryo, and this embryo should be anchored with this endometrium via alpha V beta 3 integrins. If these 3 things are there in the endometrium, endometrium should be pregnancy conducive endometrium. At that time, there should be very good vascularity. Endometrium should receive this blastocyst which is coming from the ostia of the tube. We all are born in fallopian tube. Womb is resting in the garden of ampulla, waiting for beautiful or handsome sperm from the cervix, from the uterine cavity into the tube. They will meet in this garden. Then there is formation of 2 cell, 4 cell, 8 cell and zygote. At this blastocyst level, this embryo is dipped into this endometrial cavity at the level of maximum implantation potential point, with good endometrial receptivity, good quality embryo, and very good environment with good pinopodal activity, presence of osteopontin and alpha B beta 3 integrins. Recurrent implantation failure does not have an universal definition. If you ask for the Eurasian Society of Human Reproductive, that is ASHRE, or pre-implantation genetic screening, that is PGD consortium, they define a recurrent implantation failure as a failure to achieve clinical pregnancy after equal or more than 3 unsuccessful transfer of high quality embryo, or after the cumulative transfer of more than 10 embryo in multiple transfers. If you see the British Fertility Society policy, their practice guideline define that RIF as a presence or absence of positive pregnancy test after 3 consecutive transfer of good quality embryo. So you see, always there is a tug of war between the British Society and ASHRE, that is European Society. And again, there is one society, that is American Society. They are also differing in the definition of recurrent implantation failure. But clinically, if they have got more than 3 unsuccessful pregnancy, you consider them as a recurrent implantation failure. If you see, the incidence affects almost 10 to 15% of the couple undergoing in IVF embryo transfer. And this is the latest consensus of 2021. So what are the risk factors involved in this recurrent implantation failure? Most common is maternal advanced age, elevated BMI. Nowadays, with healthy style of a lady, you can say more BMI patients. They are smoking, it not knowing as a taboo. is smoking and alcohol is considered as a high society, and stress involved in the life they are living, the quality of life because of the earning and going in this journey of increment in the job or getting the social status. Male are also not devoid of this. They are also suffering from smoking, alcohol, stress, and everything. And these risk factors are there for causes of recurrent implantation failure. What is the effect of aging? We say age is there. If you see when she delivered or when she delivered a lady or a baby, ovary is full of lots of element, lots of ovum. Then by the age of puberty, there are certain amount of ova are there, and in the reproductive failure, every month she is losing one or two ova. If you see the magnitude of odds of recurrent implantation failure is lower in younger women, that is less than 35 years. Aging in women causes reduction of the ovarian reserve and oocyte competence. Advanced maternal age impacts fertilization rate, embryo development to the blastocyst stage, and aneuploidy. So advanced maternal age affects all these things in a woman. So what is the adverse effect of obesity on reproductive potential? Obesity exerts its effect upon the conception and implantation through a cumulative impairment of the several processes. Obesity affects ovulation, oocyte maturation, endometrial development, uterine receptivity, implantation, and miscarriage. If you see this figure on this slide, summarize the report of effect of obesity upon the hypothalamo-pituitary ovarian uterine axis. If you see, woman has to suffer from hypothalamus, pituitary, ovarian, and this all affects on the uterus. There is a very good retrospective study of more than 22,000 women. Those who had undergone the frozen embryo transfer cycle demonstrated that the obese woman has got significant decreased chances of implantation, that is the adjusted ratio of 0.80. Clinical pregnancy rate is 0.81. If you see the live birth rate, odd ratio is only 0.070. Male with BMI more than 28 exhibits a significant lower fertilization rate, decrease in the good embryo quality rate, decrease in the pregnancy rate, and sperm DNA fragmentation is very high with shorter sperm telomere length. That is, shorter sperm telomere length is observed in the male with obesity. There is a noxious effect of smoking on reproductive function. Each stage of reproduction, folliculogenesis, steroidogenesis, embryo transfer, embryo receptivity, endometrial angiogenesis, or uterine good flow in the uterine myometrium is target for cigarette smoking miracle. So smoking have got lower estradiol level in the ovum stimulation. Smoker causes twice higher number of IVF attempts to conceive as a non-smoker. And smoking has got negative effect on the endometrial thickness on the day of embryo transfer. So second-hand exposure to smoking, that is passive smoking. Suppose I am smoking and person who is sitting in front of me has got more chances, 52% higher risk of implantation failure and 24% of reduction in live birth because they are inhaling live carbon monoxide. Same way, the effect of alcohol consumption on reproduction. On female reproduction, studies have demonstrated that association between alcohol consumption and fertilization, likelihood of failed fertilization. There were 18% greater odds for failed implantation among women drinking 1 to 7 drinks per day. Women drinking white wine weekly has got 22% greater odds for failed implantation. Men drinking beer daily also were observed to have greater likelihood of implantation failure. If you see, there is alcohol effect on steroidogenesis because increased estrogen and decreased progesterone level, decreased hepatic oxidation on estradiol to estrone, and decreased expression of LH, HSHC receptor on glandular cell. This will also affect on the oviduct. Decreased oviduct smooth muscle contractility. In this all oviduct, there are small ciliaries are there, and they are moving the ovum which is released from the ovary. It is engulfed by the 2 to 3 millimeter of water pressure from this fimbria into this oviduct, and from this oviduct, the ciliary movement of the oviduct which is making ovum to rest in the garden of fecula. There is also detrimental effect on the uterus. Pre-implantation developmental defect will be there, decreased cytoprophoblast or cell proliferation, and increased apoptosis. Male factor has also got higher significant rate of recurrent implantation failure. Individual response to stressful stimuli can differ dramatically, covering to the major issue of stress response rather than stress itself. The figure on this slide describes that the vicious circle between the stress, quality of life, and altered female fertility. Stress is common in both male and female. Patient with low cortisol level on the day of egg retrieval, chances of pregnancy will be higher. IVF failure leads to higher rate of both anxiety and depression in immediate period after negative IVF outcome. If you see the patient, those on pre-IVF, if there is low cortisol on the day of egg retrieval, there is less chances of fertility. And post-IVF, if you this is a vicious cycle. Once he knows that there is no pregnancy, all the stress relieved is also affected in the next pregnancy cycle. Is there. Male has also got significant part. Higher order of recurrent implantation failure in IVF patients is associated with male factor. That all the effectors are chromosomal abnormality, sperm factors like sperm chromosome, gene mutation, sperm quality, age of male, miscellaneous factor like mannan binding protein, that is MVP, therapeutic agents like air pollution, medication, ionizing radiation. These all affect on implantation. Studies have demonstrated that DNA, that is deoxyribonucleic acid, fragmentation has been associated with reduced natural conception, IUI outcome, and fertilization and pregnancy rate in ART cycle. The performance of sperm cell of poor methodology is low and correlated with high rate of DNA fragmentation. 28% of sperm DNA of infertile men exhibit DNA fragmentation compared to only 13% of the fertile male. So chromosomal, sperm, paternal and miscellaneous factors are there for the significant role in it. So what is the pathophysiology which is involved in this recurrent implantation failure? If you want to achieve normal implantation, or what should be the strategy of achieving implantation, that depends upon the proper structure and adequate receptivity of the endometrium. This slide shows that various factors essential for creating in utero environment for appropriate endometrium receptivity, trophoblastic proliferation and nesting. We all know there is response of Th1 and Th2 cytokines. Whenever in COVID era, everybody knows regarding the antigen antibody reaction. Whenever there is any antigen is involved in our body, on that antigen there is formation of antibody. And there are two types of response, that is Th1 cytokine response and Th2 cytokine response. If there is activation of Th1 cytokine response, that is detrimental, that is negative, because of not good having good environment. Increasing the natural killer cell, formation of symmetric and antigen antibody reaction. There is decreasing the protective cytokines. Therefore, there will be abortion of the fetus. But we have to thank our Almighty that our mother has generated enough amount of Th2 cytokines, that is anti-inflammatory cytokines, and they have got decrease in the natural killer cell. There is formation of asymmetric antigen antibody, and there is formation of protective cytokines. If all are there, this is known as pregnancy conducive endometrium or pregnancy immunomodulation. If these three things are there, then there will be very good implantation of embryo into the uterine endometrium. If these things are not there, there will be a recurrent implantation failure. So there are various mechanisms involved in recurrent implantation failure. That is because of the immunological factor, dysbiosis, infection, that is chronic endometritis, depends upon the endometrial thickness, anatomical abnormalities, genetic abnormalities, and male has sperm morphological deficiency. As I talk about the natural killer cell, this natural killer cell in the peripheral and uterine, peripheral natural killer cell, the level of CD56 and CD16 cells in women with IVF failure was significantly higher, those who have got successful IVF. Same like uterine natural killer cell, the density of uterine natural killer cell on the endometrium from women with recurrent implantation failure, IVF is significantly higher than those who have got control group. So these are the events which shows that increase in the natural killer cell in the peripheral and in the uterine endometrium have got detrimental effect. When we talk about natural killer cell present with the increased number and or with the abnormality in the increased cytogenic phenotype, all the events entailed in normal embryo transfer are dysregulated. Due to their increased cytotoxic phenotype, this abnormal uterine natural killer cell attack and destroy extravillous trophoblast, that is EBTs, and furthermore the secretion of growth hormones and cytokine is also compromised. reducing the invasion of EVTs into the decidua. Ultimately, abnormal uterine killer cell fail to promote remodeling of the spiral arteries. This even lead to implantation failure or to an impaired pregnancy maintenance, eventually resulting in miscarriage. There is a very good cross-sectional study that demonstrated that the level of peripheral natural killer, that is CD56 and CD16 plus cell in women with IVF failure was significantly higher than those with successful IVF. Another study same has demonstrated that uterine natural failure share in women with recurrent menstrual failure is significantly higher, that is 14.5% compared to 5% in women with endometrium of the control woman. Time shifting from the T helper cell Th1 to Th2 is of utmost importance for implantation. During the implantation phase, Th1 cells are infiltrated at the residua and regulate the tropoblastic invasion by participating in the tissue remodeling and angiogenesis. We are implanting our cell into the endometrium by the phagocytic activity. When this blastocyst reaches the endometrium, blastocyst has got syncytotrophoblast and cytotrophoblast. This both cell has got very good phagocytic activity. They will phagocyte the endometrium. We are implanting ourselves into the endometrium, and that is formation of remodeling of the tissue and angiogenesis. When this implantation phase is over, the Th2 cells become dominant and promote allograft tolerance. A high Th1 Th2 cell ratio is linked with more than 4 implantation failure cycles and more than 2 pregnancy loss. The tumor necrosis factor alpha, the TNF alpha concentration is significantly higher in the group of embryo implantation failure. The patient with RIF has got high presence of autoantibodies, that is ACA, that is immunoglobulin G, immunoglobulin M, and anti-nuclear antibody, that is ANA in this sera. The presence of ANA in sera increases the risk of RIF after embryo transfer in women with fertilization ratio. So all the patient has to undergo the APLA test, and if it is positive, then we have to treat those patients with autoantibodies in recurrent implantation failure. What is APLA? That is antiphospholipid antibody. APLA affects implantation, presentation, as well as early embryonic development and exerts detrimental effect during pregnancy by directly binding to the trophoblast. A review study analyzed the role of APLA in etiology effect of female vector integrity. The prevalence of APLA antiphospholipid antibodies among women experiencing recurrent implantation failure has got 9%, was found to be significantly higher than the woman with the fertile, that is 1.5%. Woman with APA has got lower implantation rate, that is 14%, with those with antibodies. So APLA affect implantation, presentation, embryo development, and it has got every detrimental effect on directly binding to the trophoblast. So what is there? Inherited thrombophilia. Thrombophilia is condition where the blood has got elevated tendency to form clot, that is hypercoagulability. Microvascular clotting of the vessels of the decidua during implantation due to hypercoagulability causes RIF infection with thrombophilia. Various observation studies have investigated the relationship between the inherited thrombophilia and RIF. There are studies suggested that inherited thrombophilia may play a role in the etiology of RIF, and these women should be screened for thrombophilia. There are 3 different studies done by Azam, Cuban, and Siller. They all said that is prevalence of thrombophilia in all these patients, but best study is 0.003 p-value, that is azamandatol prevalence of thrombophilia in control group was 9.1, while the patient is 26.7. What are the clinical implications of dysbiosis of female reproductive? The proposed mechanism of interaction between the microbiota and endometrial cells suggested that the dominance of non-commensal bacterial communities can be weaken the integrity of endometrial mucosal barrier. Now the pendulum swings. In India, since long, we are knowing that in vagina, if endometrium is good, we should have a very good lactobacillus. And recent times, they are giving the douche from the water of curd. That the curd contains the maximum lactobacillus, and that lactobacillus are good for the commensal of, or there is a dominance of the non-commensal bacteria. They are present, there will be very good cell activity. So in this turn could further weaken host defense mechanism and allow pathogens to enter into the endometrial stroma and elicit profound immune reaction. Aberrant stimulation of T cell either directly by invading pathogens, reaching the mucosal barrier, or indirectly by the absorbed bacterial products. The result is disabled in cytokine production in the favor of pro-inflammatory, that is Th1 type. The Th1 type endometer is not good. There is a abortive mechanism. So dysbiosis is linked to spectrum of clinical disorder related to the female reproductive system, which has been described in this figure and this slide. That is the preterm labor is there, chorioamnionitis, placental dysfunction, RIF, chlamydial infection, PID, ectopic pregnancy, endometriosis, bacterial vaginosis, infertility, etc. So if there is a very good vaginal environment, a vaginal ecosystem is good, vagina should be flooded or it should be good with good protective commensal of all bacterial pathogens. There are all pathogens of the lactobacillus variety. It should be there, then it should be very good and microbiota in the infertility women. This is very good study published in Kitaya et al. It characterized the microbiota in endometrial fluid, that is compared to the vaginal secretion in women with recurrent pregnancy law. The Shannon index of EF, that is endometrial fluid microbiota in RI group, was significantly lower than the control group. The woman with RI possesses fairly different biobeta condition. This, if you see, this is a control and this is recurrent implantation failure. We can see that endometrial microbiota is very low, vaginal microbiota is also defective in this patient, and its Shannon index is very high in this type of patient. So if endometrial microbiota is not good, there are chances of recurrent pregnancy failure. A study with endometrial fluid of 35 infected Caucasian women with recurrent implantation failure, they have analyzed the impact of endometrial microbiome on the reproductive system. Non-lactobacillus dominated, that is more than 90% endometrial biobota, found to be significantly correlated adverse reproductive outcome measured as the implantation, pregnancy, ongoing pregnancy rate and miscarriage rate. When compared to subject present with lactobacillus dominated, that we are talking about, the lactobacillus, it should be a very protective bacteria in the vaginal fluid. Has got, if it is more than 90%, it has got very good healthy bacteria, very good healthy endometrium, and pregnancy rate will be very high. If you see live birth, there are more chances of lactobacillus. In miscarriage, 0.75. These are the miscarriage group where there is low microbiota and no pregnancy. Then comes, if there is no good, very good endometrium of the uterine origin, then we have to think of chronic endometritis. The high prevalence of CE ranging from 15 to 16% in patients with reproductive failure. The CE, the immunosuppression comes. Requested to embryo transfer implantation is converted into immunoreaction, which hampers the correct embryo implantation. Studies have studied that high prevalence of chronic endometritis in patients with recurrent implantation failure ranging from 15 to 60%. In C, the immunosuppression requested, and there is very good relationship between the C and infertility. If there is no good endometrial thickness, embryo is not going to implant. There is a retrospective observational study with 105 women with regular menstrual cycle. Those who had undergone IVF cycle with natural conception, they are analyzed. Clinical pregnancy, not H1, and the live birth rate, that is H, were measured to the function of endometrial thickness. The pregnancy rate in women with endometrial thickness more than 7 mm was 7.4%, and 30.8% in women with endometrial thickness equal to 7 mm. A tendency of lower pregnantation rate was observed in women with thin endometrium around less than 8 mm, as well as particularly thick endometrium more than 11 mm. This suggested that the thin endometrium should be considered as an integrated negative prognostic factor for achieving pregnancy in women. So not too high is good, not too less is good. So it should be around 8 to 10 mm of endometrial thickness for good implantation. If we see the anatomical abnormalities, has got adverse effect on pregnancy outcome. We all know that submucous fibroid are associated with more than 70% decrease in the order of pregnancy and delivery status. Patients, those who are submitted to polypectomy, has got higher significant rate of increased spontaneous pregnancy than those who have not. Intrauterine adhesions occur in 8.5% of women with recurrent implantation failure. We have to do histoscopic adhesinolysis for spontaneous live birth. Implantation and pregnancy rates were also significantly low if patient get hydrosalpinx. And recently nowadays, if there is a hydrosalpinx, we are removing that hydrosalpinx or we are keeping that hydrosalpinx before it will give detrimental effect. This all secretion from hydrosalpinx into the uterine cavity will make embryo not to survive in uterine pregnancy, and we all know that this all submucous fibroid or which is implanted into the cavity or integrated into the cavity, they are not good. We have to see the genetic abnormality. Several SNPs have been reported to associated recurrent recession. So several single nucleotide polymorphism has been reported to be associated with recurrent implantation. Tumor protein, that is P53, genetic polymorphism of more than, that is R72, that is argine polymorphism of P53 gene is more frequent in RI patient compared to fertile population. Human leukocyte antigen, that is HLA-G gene polymorphism, HLA-G14 BP polymorphism is significantly correlated with RIF that correlate with the odds. The vascular endothelial factor VGEF genes, a woman carrying genetic value of VGEF, VEGF genes are at the risk of recurrent implantation failure. So all this single nucleotide polymorphism has got high risk of recurrent implantation failure. If within a spermatozoa, morphology also plays an important part in it because male contribute 50% of fetus production. There is potential risk factor leading to sperm DNA damage or fragmentation. What are the inherited sperm factors? Immature abnormal sperm, defective apoptosis, prolonged stasis in epididymis, abnormal protomization, abnormal cytoplasmic or ROS to the antioxidant ratio, chromosomal abnormalities. If we talk about the ART, the related factor are prolonged incubation period or there is a free flow cycle. Genital tract pathogenesis, if a patient male is suffering from varicocele infection, leukocytospermia, cryptorchidism, testicular torsion or testicular cancer. Some medications are there supplemented that if a patient has chemotherapy subject or antidepressants or herbal medication that you don't know, recommendation or recreational drugs or illicit drugs like marijuana, cocaine, it is very common nowadays in all youngsters. And environmental and lifestyle factors like smoking, radiation, alcohol, heavy metal, pollution, toxins, obesity, heat exposure. Heat exposure will be there if they are playing lots of time with their laptop. Laptop should not be on the lap. If you want to have a laptop, it should be covered, but there should be fan because this laptop creates lots of heat and that is detrimental for the testes. Advanced paternal age and systematic pathogenesis like prolonged fever, cancer, systematic inhibitions or diabetes now increasing in male part. So these all factors we have to see. They all are damaging the DNA or fragmentation directly or via the oxidative states. In section 4 we are saying that what are the investigations we have to carry out in recurrent implantation failure. We have to go for sperm aneuploidy, sperm epigenetics, CASA if we have got, and we have to go for DNA fragmentation test. For oocyte, we have to rely on AMH and we have to rely on the day 2 ultrasound scan for the enteral follicle count. We have to look for thyroid function test, thyroid antibody test, prolactin and free androgen index and HbA, that is glycosylated hemoglobin. If they have got more than 3 pregnancy loss, we have to go for parental karyotype in form of blanket testing or higher order IF, additional risk factors such as recurrent implantation failure. Always go for 3D ultrasound because 3D ultrasound has already replaced the virtual hysteroscopy. It will give all the things which you are watching in hysteroscopy, but if you are not satisfied, you have to go for screening of hysteroscopy, endometrial receptivity array, endometrial reception, immunological factor and thrombophilia, uterine natural killer cell, peripheral natural killer cell, endometrial cytokines, genital microbiome, peripheral blood cytokines, HLA incompatibility, inherited thrombophilia, antiphospholipid antibody syndrome. These are the investigations we have to carry out in recurrent implantation failure. What are the therapeutic intervention we have to go for recurrent implantation failure? What we can give to our patients as a treatment option? We have to give them the optimal IVF treatment or optimum in vitro fertilization treatment. If required, antithrombogenic agent if they are for thrombophilia or APLA positive. Antibiotics for infection if they are suffering from chronic endometriosis, and immunotherapy if it is required to increase the pregnancy rate in these type of patients. What is the optimal environment we can give to our patient? We have to select very good sorry very good embryo for implantation. Our transfer method should be perfect. We have to implant embryo at the maximum implantation potential point. We all know that every uterus has got different MIP points. If we see, suppose there is a uterus and this is two are the ovaries. You can write. Suppose this is the uterus and these are the ostias. This is the normal side uterus. If you have to draw a line parallel from this to this, and this will be the MIP point for normal uterus. And we have to place embryo at this particular junction with our very good transfer rate. Yes, it's the site we have to release our embryo by double sandwich method. So we know that embryo is implanted over. And every uterus, suppose there is a unique formate uterus like this. So there will be a single ostia. So their implantation potential will be here only. Suppose there is a bicornate uterus like this. Ostia is lying over here. You draw a line. And this line goes over here, very much low. So this will be the MIP point for bicornate uterus. So we have to select our method very well. Always use very good ovulation induction protocol. Ovulation induction protocol. So your patient has to find a very good quality of ovum, and always give progesterone support, because we all know when we are doing IVF, we are also picking the ovum. When we are picking the ovum, we are not only picking the ovum, we are also picking the glandular cell. And glandular cell are the mother of future corpus luteum, and corpus luteum is father of progesterone. If suppose insufficient corpus luteum is there is less production of progesterone, and this less presentation of progesterone will lead to insufficient progesterone into the uterine environment. And we all know the hormone progesterone means pro for gestation. It is essential for the nurturing the pregnancy. In first trimester, the pregnancy is nurtured by progesterone secreted by the corpus luteum. So in all IVF pregnancies, there is a deficient corpus luteum because of the less activity of glandular cell. So all pregnancy should be supported by progesterone. So all this embryo, let's first understand the embryo factor for optimum implantation. If we compare, fresh embryo transfer pregnancy resulting from frozen embryo transfer are associated with lower pregnancy weight, preterm delivery, small for gestational weight, and placenta previa and placental abruption. If we think the woman with PCODs, FET result in higher frequency of live birth compared with fresh cycle. The patient undergoing pre-GD or PGDA, that is aneuploidy, ongoing pregnancy rate is 80% compared versus 61%, and live birth rate is 77%, where significant higher in the frozen group. High responder has got higher clinical pregnancy rate and live birth rate in FET cycle compared with fresh cycle. So there is always tug of war between the fresh versus frozen cycle. If you compare FET cycle in PCOS, it is good. Undergoing PGA, it is good, and those who have got higher responder, because in higher responder you cannot implant those many embryos into the single uterine cavity. So it is best option to freeze them and go for frozen cycle. But there is always comparison. If you compare the fresh embryo transfer has got little bit higher rate compared to frozen embryo cycle, and always those who are doing all freeze all cycle, they say that freeze all is good. Suppose I am doing both fresh and frozen, so I am saying that there is equivocal result. So both has got its advantage and disadvantage depending upon the situation in which patient you are dealing with, either PCOS, PGDA, or patient has got very high response in which there is no option rather than the freeze all. There is a retrospective study, cohort study of pregnancy outcome in patient who had got cleavage state embryo, age matched with patient who had got day 5 transfer. It was observed that the cleavage state transfer was associated with significantly lower implantation rate, clinical pregnancy rate, and time. So there is again day 2 or day 3 versus day 5 transfer. And this study says that the woman with limited number of fertilized embryo of IVF-PT proceed with cleavage test transfer resulted in lower implantation rate. So these all are the implantation, on-ring pregnancy, late live birth and miscarriage, and twin pregnancies are there. You see the cleavage stage has got more chances of pills compared to single blastocyst transfer. So both has got this own importance of day 2 versus day 5 transfer. But this study definitely says that there is if you transfer on blastocyst stage, there will be more number of clinical pregnancy rate. The following interventions are supported by the literature for improving the pregnancy rate. Like always we are doing abdominal guided ultrasound, this is our policy. Remove the cervical mucus, we are always using the soft catheter. Immediate embolization once the embryo transfer procedure is complete, there is no need for rest, but if we, even though we say that there is no need of rest, people will are taking rest. And placement of embryo transfer in the tip of upper or middle central area or uterine cavity more than, and this I had explained that this should be done at the maximum implantation potential point. So if you are taking all this very good care, these are the recommendation by ASRM, the pregnancy rate will be very good. There is a very good systematic review and meta-analysis published from 11 studies, that is Young et al. Evaluated the effectiveness and safety of long-acting GnRH agonist and antagonist ovulation induction protocol. 1994 women were belonged to the long-acting GnRH protocol against the follicular protocol group of 1678 to GnRH antagonist protocol. The long-acting GnRH antagonist protocol was beneficial in improving the live birth rate of clinical pregnancy rate and implantation rate. The incidence of OHSS was significantly lower in women under Welfare. There is also advantage and disadvantage of all this study. You all know that gold standard is GnRH agonist protocol, and nowadays everybody is going for antagonist protocol. So that depends upon the systematic review. Both has got very good result. Depends upon the situation. If you got very good time, you can have a GnRH antagonist protocol, that is we are known as long protocol. Antagonist protocol is short protocol, and whenever patient comes at any time, patient has to take less injection compared to long protocol. We have to supplement all this patient with progesterone. We all know that progesterone was produced by corpus luteum, causes the secretory transformation of the endometrium that is necessary for implantation and for early development of fertilized ovum. In response to progesterone, the glands become tortuous and secretory, and these are an increase in the stromal vascularity, thus making the endometrium both morphologically and functionally well prepared for endometrium. So all this progesterone produced by corpus luteum process the endometrium both functionally, morphologically, very good for implantation. So we have to give support of the progesterone, because progesterone plays a significant role in establishing an adequate immune environment at an early stage of pregnancy. It exerts an immunological pregnancy effect, in a part manifested by controlling cytokine production. You all know that there is the production of protective cytokines. Progesterone deficiency has been associated with insufficient endometrial maturation and inadequate regulation of inflammatory receptors. Thus, we have to support the pregnancy with progesterone, may help to establish a sufficient immune response in early pregnancy and prevent miscarriage. So we have to choose the right progesterone. Progesterone for luteal phase support can be administered orally, intramuscularly, vaginally, and people have all different variety, tablets, injection, gel, spray, everything available for progesterone. If you see the history of oral contraceptive pill, Pincus has designed oral contraceptive pill with estrogen and progesterone. Till date, ethinyl estradiol remain the same. All the changes are there in the progesterone, because the thing which has got maximum effect has got maximum side effect. Because of progesterone side effect, we are here to get progesterone which gives the minimum side effect to the patients. That's why there is different variety of first generation, second generation, third generation progesterone are available in market. If you see, there are two giants in the market for luteal phase support, that is oral micronized progesterone and dydrogesterone. Oral micronized progesterone has got low bioavailability because it is associated with systematic adverse effects such as drowsiness, dizziness, headache. If we give intramuscular injection, there is chances of pain at the intramuscular site and abscess. Micronized vaginal progesterone is associated with administration side effects such as vaginal irritation, there is discharge from the vagina, and patient doesn't find very good because in Indian scenario nobody wants to put anything, just like in Western countries they are want to put everything into the rectum. Here we don't want to put anything into the rectum, only these are things for the excretion. So there is only option available, that is dydrogesterone, which is oral, more potential, and it has got very good improved bioavailability. So oral dydrogesterone is the right choice for progesterone because it has got high selective progesterone, which is due to its retro structure, binds almost exclusively to the progesterone receptor. Due to its better bioavailability and the progestogenic nature of the metabolites, it is equivalent to 10 to 10 times lower for the endometrial proliferation. Dydrogesterone has got no affinity for androgenic, estrogenic, glucocorticoid, mineralocorticoid receptor. It is favorable for safety and tolerability profile in pregnancy with both mother and child. And since years together, 1960, dydrogesterone is available worldwide, and more than so many million babies are delivered till date without any side effect, and it is better bioavailable. So dydrogesterone, which is documented evidence of immunomodulation. We all know for normal pregnancy there should be very good PIVF, the progesterone receptor activation. Increase in progesterone blocking factor, that is PIVF, block the cascade of TH1 to TH2. It is SIP2H2, that is a protective cytokines. It goes for embryo protective immunomodulation, formation of protective cytokines. There is formation of asymmetric antibody, decrease in the natural killer cell, and increase in the PIVF. This will all protect the embryo or fetus. So dydrogesterone induces TH1 to TH2 cytokine C. You all know that is pregnancy immunomodulation. Dydrogesterone also induces the PIVF production, because we have proven in laboratory settings that if we give higher doses of dydrogesterone and we take peripheral blood, there are more P receptor positive cells in the circulation. So with this dydrogesterone, we have got very good increase in the PIVF. Immunomodulatory effect of oral dydrogesterone drives that immunomodulation either through via the progesterone inducing blocking factor, which mediates the immunomodulatory effect of progesterone during pregnancy and induces a cytokine shift toward TH1 to TH2 cytokines. Dydrogesterone not only causes inhibition of natural killer cell cytotoxicity, but also fertilizes the condition conducive for the pregnancy. Dydrogesterone not only provides optimal secretory transformation of the endometrium, we call it the pregnancy conducive endometrium, and also provides systematic immunomodulation, which imports to protect the fetus. It is expresses antigen for it, the maternal immune system. So all this level, dydrogesterone is very good, affecting in the increasing PIVF. In addition to the bioavailability, receptor binding and activity are pivotal pharmacological features. The rapid degradation of orally administered progesterone results in high concentration of circulating metabolites. The progesterone metabolites, which circulating at high level, may bind to progesterone receptor and interfere with the normal progesterone action by interfering with the transcription cofactor of DNA binding. Alternatively, the 5-alpha and 5-beta reductase pregnenolone are also known to have high affinity for bi-aminobutyric acid, that is GABA receptors. Such receptors are present in the reproductive tract, and their activation may adversely affect the pregnancy outcome. It is known that dydrogesterone, the orally administered progesterone, upregulate the production of TH2 cytokines, downregulate the production of TH1 cytokines production. Interestingly, the metabolite, that is dihydrodydrogesterone, is like the parent molecule dydrogesterone, suppresses the production of pro-inflammatory cytokines, interleukin factor gamma, tumor necrosis factor alpha, and upregulate the production of anti-inflammatory cytokines, interleukin 4. Dihydrodydrogesterone retains the immunomodulatory effect of dydrogesterone. Dihydrodydrogesterone induces also nitric oxide synthesis. When there is activation of, we are giving arsenic acid. When we are giving arsenic acid for vasodilatation, it is a nascent vasodilator. When arginine is converted into citrulline, there is formation of nascent nitric oxide. And this nitric oxide dilates the vessel, endometrial vessels, increases the patient circulation, and improves pregnancy outcome. You can see that lots of paper are available for vasodilatation in the renal origin. Same effect is also seen in the uterine origin because mesonephros and paramesonephros are delivered or are embryologically same from the same embryology. So if it is useful in renal origin, it also useful in uterine origin. So increasing, if you use dydrogesterone, it also increases the nitric synthesis production and it will give very good endometrial receptivity. So progesterone upregulates the HLA-G gene expression through a novel progesterone receptor response element by generating the regulatory cell and modulating the activity of dendritic cell, T cell and natural killer cell. Increases expression of HLA-G might contribute to a favorable microenvironment in the decidua. Thus, one of the site of progesterone action in promoting normal gestation and regulation, that is HLA-G expression. So progesterone upregulates HLA-G expression and promotes normal gestation. So oral dydrogesterone has got very good clinical evidence in women undergoing assisted reproduction technique, and we will discuss there are lots of meta-analysis of oral dydrogesterone by increasing the clinical pregnancy rate compared to microvaginal progesterone. If we see the Cochrane review, there is no difference in live birth and ongoing pregnancy rate between the systematic and micronized progesterone, synthetic progesterone group, which has got very higher clinical pregnancy rate. Lots of RCTs compare that oral dydrogesterone is well tolerated route of progesterone delivery with a similar safety compared to micronized vaginal progesterone. And there are phase 3 trial of oral dydrogesterone, that is 30 milligram, has got same efficacy and safety as MVP gel and can be used as a very good agent in luteal phase support. If we see, there is a meta-analysis of 8 randomized control trial compared to dydrogesterone and progesterone for luteal phase support in women undergoing ART. A total of 3,809 women undergoing ART studies from 8 different studies included 1,253 women on a dydrogesterone group and 2,286 women on MVP. Oral dydrogesterone were found to be associated with improved clinical pregnancy rate when compared to micronized progesterone, has got no very good clinical pregnancy rate. So this study suggested that the oral dydrogesterone is better option for luteal phase support in women with ART compared to micronized progesterone. A Cochrane review was also conducted to determine the relative effectiveness of various types of progestogens for luteal phase support. They provide a subfertile woman undergoing assisted reproduction. There is no difference was observed in the live pregnancy rate between dydrogesterone and micronized group. The dydrogesterone group has got little bit higher pregnancy rate compared to micronized progesterone. So this study suggests that dydrogesterone is better option for women with luteal phase support. Lotus 2 trial we all know was conducted, and it is the first trial which is double blind, double dummy, open label, multicentric parallel group trial in this 37 different IVF centers. And this is the one of a kind of study which is double blind and double dummy, so patient doesn't know that what they are giving, doctor doesn't know that what they are giving to the patients. So there are oral dydrogesterone versus micronized progesterone gel in terms of pregnancy rate, 12-week gestation followed luteal phase support. It was a randomized open label multicentric parallel phase 3 done in 37 IVF centers. The safety profile of both the groups were compared. The proportion of subjects with at least one treatment emergent event in the oral dydrogesterone and MVP group was 53 and 46% respectively. Study also conducted that oral dydrogesterone is well tolerated route of progesterone with similar safety compared to micronized progesterone. This study, Lotus 2 trial in Chinese subgroup of patients. The study was a prescribed subgroup analysis was performed in 239 Chinese male subject. 239 subjects with oral dydrogesterone, and there is a difference of 9.4% in favor of oral dydrogesterone with ongoing pregnancy of 12 weeks per gestation. So oral dydrogesterone 30 milligram has got same efficacy and safety as micronized vaginal progesterone gel and can be a very good choice for luteal phase support. What SRI says? Dydrogesterone is recommended in 2019 European Society of Human Reproduction and Embryology guideline for ovarian stimulation in IVF and ICSI cycle recommended the use of dydrogesterone for luteal phase support, and it is compared to progesterone. Dydrogesterone has got similar ongoing pregnancy rate, safety, tolerability, and better patient compliance. For antithrombotic therapy, there is a systematic review of different meta-analysis done. The effect of low molecular weight heparin. Intervention group was 127 women with recurrent implantation failure and control was 160. The use of adjuvant low molecular weight heparin is also associated with 79% improvement in pregnancy rate. Since birth, fetal heart positive, we have to give low molecular weight heparin, and people are giving just post-transparent. There is a pakka case of APLA or antiphospholipid antibody syndrome. You have to give them low molecular weight heparin every day, that is 40 units, before 15 days of planned cesarean or delivery. It will decrease 78% reduction in the miscarriage rate and no significant trend towards the improvement in IR. So in women with more than 3 RF, the use of low molecular heparin and adjunct to IVF treatment is significantly improving the pregnancy. Various studies have evaluated the effect of several different immunological therapies to increase the rate of implantation. This slide summarizes the result of various treatment options which is available for implantation. Like we can use tacrolimus, PBMS, GCF, and PRP infusion. These all are in the experimental studies, and nobody gives 100% sure that if you use tacrolimus or PRP infusion, pregnancy rate will be very good. But as an adjuvant, you can use immunotherapy. Chronic endometritis associated with infection is also common in women with RIF. Women with CE, that is chronic endometritis, have lower pregnancy rate, implantation rate, and live birth rate. So we have to give them antibiotic to improve the significant outcome. These all are patients with implantation rate. If you give antibiotics, implantation rate, clinical pregnancy rate, and live birth rate are very good. So you have to see which type of bacteria is there, and you have to give them antibiotic. This is the proposed treatment for recurrent implantation failure. We have to select the patient, we have to optimize the lifestyle, we have to see for genetics, we have to see for PGA, all 3D ultrasound, all the blood investigation, we have to give them the psychological support. Tender loving care is very good in the patients. Then we have to supplement with vitamin D. In the context of design treatment of thrombophilia, we have to give them low molecular weight heparin. Immunological investigation, we can go for natural killer cell, ANA. In the treatment of IVIG, GCF, endometrial stretching, sperm DNA fragmentation, we can go for antioxidants, and recently we can go for IMSI, so we can select the very good morphological sperm for the patients. So what is the proposed management? During the treatment, we have to go for very good endometrial receptivity, all the investigation for the serum progesterone at the end of follicular phase. And we can give higher treatment with very good Prozac or so freeze-all cycle or no FET. For investigation, tropectoderm biopsy or NGS, and for aneuploidy we can go for genetic testing aneuploidy. For ET we have to use very good soft catheter. It should be always done on ultrasound guidance. Always put the embryo at the maximum implantation potential point. After the treatment, we can go for, if they are not still conceiving, we have to give them the option of sperm donation, embryo donation, and oocyte donation. If uterus is not good, we can allow them for surrogacy. And best option, till date we have done more than 89 adoption. This is also very good service to the society. We can give them the option of adoption, and they can become the foster mother and father, and they are giving very good life to a illegitimate child or child who have got no mother and father. So as the key message, let us summarize. Recurrent implantation failure is complex problem with wide variety of etiologies and mechanism as well as treatment options. Women with RIF should be offered appropriate investigation to rule out the underlying causes for recurrent failure. The main treatment strategy in couple with RIF is to improve the quality of embryo transfer and receptivity of the endometrium. We have to identify the factor predisposing the recurrent implantation failure will make possible for the individual treatment plan. So all treatment should be individualized. Neurological factor as well as positive pregnancy outcome of oral dydrogesterone make it very effective for the progesterone support and luteal phase for our patients. So at the end, we don't want recurrent implantation failure. We have to treat them judiciously, and every time, everybody should be happy. So So it is a time to be happy is now, place to be happy is here. So everybody should be very happy to do this implantation failure, and we should be thank you to our mother that our mother generated to nurture us. Thank you very much. Now I'm stopping my sharing, and if you want to have